Hello, my name's Dale Adams from Planning Ahead of Time, and today I'm talking with Sarah. Sarah, would you like to introduce yourself?
Hi, my name's Sarah McDonald, and I work with secondary breast cancer patients.
Okay, and you've been working in cancer care for many years now.
Yeah, around about 7 years now. Yeah.
Okay, and now you specialise in breast cancer care.
I specialise in secondary breast cancer patients, so where the breast cancer has spread and the condition is no longer curable.
Okay.
Treatable, but no longer curable.
Okay. Now, one of the things that you and I have spoken about quite a lot, and I know you've done many presentations on, is respect forms. And I think a lot of people don't really understand what they are. I would include myself in that. I've done a little bit of research on it, but maybe you could tell us what is a respect form and how would somebody use it?
Respect form is a recommended summary plan for emergency care and treatment. So it's a form that the patient holds in their possession, and they take it with them if they have any unexpected hospital admissions, and they keep it at home so that, if they have to have any emergency care, any professional that's looking after them can have sight of the form and see what the patient wants. Their wishes are detailed on it.
Okay. Now, so is this something they should carry around with them as well when they go out and about?
Not necessarily, no. It just needs to be with them if they are admitted into hospital, or if emergency services are called to their home.
Okay.
So the idea is that if they are admitted unexpectedly into hospital, the respect form goes into their notes so that all health professionals that have any contact with them know exactly what their wishes are. And if an ambulance is called to their home, the paramedics have the respect form so that they know exactly what their wishes are.
Okay. Now, my understanding is the respect form is actually done with a medical practitioner. It's not just something you write and sign yourself. Is that right?
That's correct. Yeah, that's absolutely correct. So I do it with my patients. I'm very passionate about doing it with my patients because I think it's very empowering. It makes sure that anybody that's looking after them knows exactly what they want. And then I often get it signed by a consultant. So either their oncology consultant or the emergency care consultant when they come into hospital, they'll have a look at it and sign it just to confirm that they agree with everything that's on there.
Okay, you've just said to make sure that they agree with everything that's on there. So who makes the final decision about what's on the document?
So the document has got various things on it. It has things like whether they've got power of attorney in place, if they've got any documents, where the documents are, just so that in the case of an emergency where they can't speak for themselves, people know where to find things. It has a space for why they're holding a respect document. Although anybody can have them, it does tend to be people that are at risk of a sudden deterioration. So, people with sort of terminal illness, especially. It has an area where it talks about the patient's priorities. So, what are their priorities? Do they want to be kept alive no matter what? Even at the expense of comfort, or do they want to be comfortable and cared for, even at the expense of longevity of life, basically? And you don't have to decide one or the other. There's a scale. So you can go, I'm favouring this, I'm favouring that. Then we talk about escalation in a clinical situation. So whether they'd want to go into ITU, how far they'd want us to go, where they'd want to be cared for at the end of life, and that sort of thing. There is the DNAR box on the bottom. So, whether they are for CPR, whether they are not for CPR. But when you're in hospital and you're under the care of a consultant on a ward, the consultant will make the final decisions based on your best interests. So even if you've signed that box to say that you want CPR, these things aren't contracts. They're not demands for treatment. If a consultant, looks at the patient and said, CPR is not in this patient's best interest, we're going to cause harm by doing CPR and we're not going to cause any good, then, the decision will be taken not to perform CPR. So it isn't a contract. It's a record of the patient's wishes. CPR is a difficult one because, people have a very unrealistic view of CPR. People often have only seen CPR on television, in dramas, a few pumps on the chest and they take a big deep breath and live life happily ever after. And it's very, very, very different to that in reality. CPR is brutal. We crack ribs, we shove things down people's throats, we can cause internal bleeding, we can cause, brain damage, hypoxia. Less than 20%, in fact, I think it's less than 17% of patients leave hospital after a round of CPR. And the way I always explain it to my patients is, if a heart is stopping, as part of a natural dying situation because other organs are shutting down, it doesn't matter how many times we restart the heart, it's not going to get the rest of the body restarted. So the only way we would do CPR successfully is if it was just the heart failing and we restarted the heart and fixed the problem. If the rest of the body is failing, restarting the heart, it's not going to be in the best interest of the patient.
And of course, the other thing is if the heart and like the blood and the oxygen isn't circulating enough and you don't have the oxygen for a period of time, then actually the brain is then going to be affected. And that could mean coming round with brain damage, couldn't it?
Absolutely, yeah. Some people never come round. Some people just never regain consciousness. They're just being kept alive. So, CPR's a difficult one to talk about, but often, when it's explained to my patients, they will often say, actually, no, I don't want that. It's very traumatic. The patient often, well, I would hope, doesn't know anything about it, but it's very traumatic for the family to see. It really denies patients that dignity in dying. It denies them that, last moments with their family. And if we're expecting a heart to stop, we will see the signs of a heart stopping. So as healthcare professionals, we'll be doing observations and we'll see the signs of a heart stopping. And if one stops unexpectedly, obviously that's a little bit different. But when somebody's dying, we would expect the heart to stop as part of the natural dying process. So we wouldn't then want to be starting to trying to restart the heart.
Yeah. Well, as you were talking about it, you mentioned the DNA tick box, and people, I believe, would know that more commonly as the DNR, but there has been a change in that terminology, hasn't there?
DNA CPR, so do not attempt CPR, cardiopulmonary resuscitation, is what we generally use, yeah.
But at one point it was, people consider it as sort of do not resuscitate, but now it's actually known as do not attempt resuscitation. So I think just changes that.
Yeah, and that doesn't mean that we're not going to treat anything else that's reversible. And what I often write on because a lot of my patients are quite, they have secondary breast cancer, but other than that, they're quite well. So, I often will write, and this is depending where they are in their disease trajectory, obviously. I will quite often write, for any reversible conditions to be treated. So, people will say, I want to be admitted to hospital for IV fluids, IV medications, antibiotics, etc. But then we won't escalate to ITU and keep people alive artificially, and if they deteriorate to the point where CPR is being discussed, then often it will be a DNA CPR. But some patients are, they want the CPR box, that they do want CPR, and that's fine while they're fit and well. And these things are meant, as to be changed. They're meant to be changed as the situation changes. So, when they come into my clinic to have their discussions, that clinic is obviously then open to them. And, as they go along, they say, if they get more poorly and they don't want admission to hospital, they can change that respect form and say, I don't want to be admitted to hospital anymore. Actually, I want things, to take its course. So, we also do that.
Yeah, so really it is about dynamic planning, isn't it?
Yeah, absolutely. It's very empowering, because people they write all sorts of things on these respect documents, but the burden on the family, if there's been no discussion at all, the burden on the family, if somebody takes a sudden turn for the worst, it's horrendous. I have families that did I do the right thing? Is that what she would have wanted? And that's a horrendous thing to witness after somebody's died, because you want them to be at peace that everything happened, as their family member would have wished. So there's nothing worse than seeing that. So, these forms, if nothing else, they open up that dialogue with the family. They open that discussion, and they can have a chat, because often if the patients kind of will say, I need to talk about this, the reaction you'll get from the family is, that isn't going to happen. We're going to fight this. You're a warrior. We're going to battle this. And all these kind of fighting words come in. But in reality, actually, it's not a battle, because the cancer will always win. And it's not fair to see it as a battle, because the cancer will always win. So these conversations need to be had. And it's uncomfortable and it's not a nice thing to have to talk about, but it's a lot worse than when you're having to talk about it when it's actually happening. It's a lot worse. So talking about it when somebody is relatively good, relatively stable, that's the best time to talk about these things, when the patient can make really clear decisions about what they want, what they don't want, where they want to be, and other things practically. If a patient thinks in their head, right, I want to be at home, practically that needs to be discussed, because there may be young children in the house, there may be elderly parents. That has to be discussed, because if that is discussed at the end of life, and then the practicalities of that mean that can't happen, the patient then is faced with not having what they have thought in their head was going to happen, and that can make the patient feel quite rejected and, not cared for, and it can cause quite, a nasty feeling. So that needs to be discussed and settled before it happens. Otherwise, we only have one chance to get it right, dying. And if we don't plan for it, often it will go wrong.
Yeah, I completely agree with you with regards to the discussions, anything towards end of life and planning in the discussions, but also you're just talking then about somebody dying at home. I think it's quite common that people want to die at home, but I also know that when I was faced with that circumstance with my mum, I really wanted to be where there were medical professionals that could help, that could ensure that she wasn't in any pain, that could actually guide me and my family through that process with my mom. So, and that really gave me reassurance and peace. But I also felt it was the same for my mom, because she had that help there. So I know that you work specifically in the secondary breast cancer area, but I think this is anybody who's actually suffering or is coming towards end of life or has a life-limiting condition. These things need to be considered very early, including the respect forms, as well as other forms that can actually help make sure that people know what you want.
Yeah, dying at home is, a lot of people, that is their wish, to die at home. But dying at home in reality is very, very frightening, both for the families and for the person that's going through it, because not having a health professional at hand all the time, when things change, it can be really scary. It can be really, really scary. So that has to be, people have to be prepared for that. And if families aren't prepared for that, it can just, it's not very nice. It really isn't very nice. And the healthcare professionals in the community, especially in this area, are fantastic. I mean, we're really, really lucky. They're very responsive. They are absolutely fantastic, but they can't be there 24/7 often. And the times in between when they're not there, especially in the night, it can be quite a frightening situation.
Yeah. I also think from that regard that people need to consider as well, somebody sort of dying in the property, in the home. I know of people that I've spoken to who haven't been able to go back into a room.
Absolutely.
Yeah, and I think that that's also something that then it's left, if you like, behind with the family, and having that, actually, will you be able to cope with the fact that your loved one died in that particular space, because so many people suffer with intense grief anyway.
Yeah.
Is it something you can cope with?
That's exactly right. And especially, like I said, when there's young children in the house, how will they feel about it? How would they feel about going back into that room? Maybe being moved into that room. It just all needs to be carefully thought about if that's the situation. So this document will open up those conversations early enough for them to be sensibly discussed, rather than when emotions are at you know their highest, and it's all happening. So it just allows for really careful planning to ensure that things go as smoothly as possible.
So to find out about respect documents, obviously people can look online for it, but if they want to complete one, I believe you actually get them again from your local doctors or medical practitioners.
Yeah, the GPs will complete with you. If you've got any contact with the community palliative care teams, they'll complete them. The hospital teams will complete them. Often they'll be completed when you're admitted to hospital anyway. If patients that are at risk of sudden deterioration, they like to have an escalation plan in place, because patients can deteriorate really quickly, and one minute they seem fine and the next minute things are going wrong. So the hospital teams like to know, they like to have an escalation plan. And it's not about, a lot of patients, they think, or they don't want to do, the CPR, they don't, but it's about doing what the patient wants and causing no harm. And often, that's their priority. They don't want to escalate to ITU. They want a clear escalation plan. What are we doing here? Where is, because the thing is, if you go into hospital, a lot of the medical teams that will be looking after you won't have access to everything that's gone on in your care. So they won't know where you are in your cancer journey. They won't know, what your prognosis is. So they need to have that escalation plan clearly written, so that they know how far to take things without causing harm.
Yeah, and I think, again, I'm taking it back to sort of my experience of it. I'd not heard of a respect document until my mum went in for an operation and Lewy body dementia. So her life expectancy was going to be one of deterioration. And obviously that can be very prolonged with dementia, although Lewy body is one that sort of shortens life. And at that point, the respect document was discussed, not because my mum was generally in her physical health unhealthy, but her mental situation meant that her life was not going to be what and she would have wanted it to be in the future, and completed the form. Because had anything gone wrong in that operation or subsequent to the operation, again, a resuscitation attempt, and I do like the fact that it says that it's an attempted resuscitation, because DNR does imply that you can automatically resuscitate anything, which again is what we see on TV, as you write. So the AR does mean that it's attempted, but it was signed because she didn't have cancer. She was healthy in her body but not in her mind, and of course that then is something that would have been made even worse potentially by
absolutely
go through that.
Yeah, absolutely. What we are aiming to do in these situations always is maintain quality of life. Yes, some drugs can prolong life, but if we're destroying people's quality of life, what are we prolonging it for? You can have 4 good months or maybe 6 really awful rubbish months. So prolonging life with things like CPR, often the quality of life is destroyed. So we have to be very, very careful as to what we do.
Well, thank you very much for talking about it. Is there anything else that you think people might need to know about a respect document or respect form before we finish this?
No, I think the main points to remember is that, the document is about empowering you to have your wishes, clearly stated, so that people aren't making decisions about your care who don't know you, because people are in charge of their own care all their lives. So actually, if you got to the point where you couldn't speak for yourself, it would be a great shame that if somebody who's never met you before starts taking decisions about your care. So I think, they're very empowering documents for people to hold. They are changeable, they're not contracts, they're not written in stone. You can change them at any point. If you don't agree with what is written on the one you're holding, you just don't hand it over. If you don't have to hand it over. It's not, we record that you've got one, and we record if there is a DNAR decision on it. We don't record anything else. So, if you don't want to hand it over, don't hand it over. You know, it's your document for, you know, to empower you to tell people what you want. And that's a really important thing to remember.
Lovely. Well, thank you so much for your time, Sarah. Really appreciate it. I think it's a really important topic. I know you do presentations on it. So if anybody does want you to do any of those, I know you actually do them for the NHS, then
I do.
so they can get in touch with me and I'll let you know about it. So
Thank you.